This is the Mechanical Care Forum, episode 396. It's season 13, and we're highlighting the McKenzie Institute International's Diploma program. We're checking back in with a few of this year's candidates, this 2023 Diploma program cohort. We're talking about how the theoretical portion finished up, the final project, how we're coping, our anticipation and start of the next phase, the clinical residency, and more. This week on MCF. Hey everyone, and welcome back. Thanks for joining us today as we continue to explore the McKenzie Institute International's Diploma program, this season, season 13 of the podcast. This episode is brought to you by the McKenzie Institute International. The McKenzie method of mechanical diagnosis and therapy is globally recognized as a leading treatment for back, neck, and extremity disorders. Personally, as you might have heard me state, MDT has made the single greatest positive influence on my practice, hands down. The McKenzie Institute International offers this diploma program to those professionals who have achieved prior certification in the method. It's the pinnacle of MDT training. Successfully completing the diploma program will place you among the world's elite in mechanical diagnosis and therapy. If you're interested in learning more, here are a couple of ways. First, stay tuned today and be sure to follow us along through this season, season 13, as we highlight this year's cohort of students through the program and get perspectives from this year's group, from some of the instructors, from some of the clinical tutors on the residencies, and more. And second, be sure to go to the website to learn more about the program and how to apply, which you'll find by clicking on the Education tab and scrolling down to the International Diploma. Just go to McKenzieInstitute.org. A quick mention that very soon, from the release of this episode in early October, the deadline for submitting an application to the diploma program will come. You can apply to enroll in this program through McKenzieInstitute.org through October 31st. Okay, so let's get to it. We've already introduced you to this 2023 cohort of diploma candidates and heard from them back within the first couple of weeks of starting the theoretical portion, the first part of the program. That was episode 391. We spoke with Helen Clare, the CEO of the McKenzie Institute International, and Richard Rosedale, the Director of Education and the coordinator of this program, in episode 392. We've also spoken to three recent candidates, now diplomats, Julie, Paco, and Adam, and heard their look back on the program and what it's done for them. We checked back in with my classmates and talked with three of the clinical instructors as well. So here we are. Upon completing the theoretical portion, we're checking back in with several to hear our perspective once we've finished with this phase. In today's episode 396, you'll hear myself, Emily, Tim, Tina, and Ruchi share retrospectively about the theoretical and especially the last few weeks and final project. You'll also hear a little on what each of my fellow candidates are anxious about related to the next phase, the clinical residency. Do stay with us through to the end to hear what's in store in future episodes. So here we go, episode 396. Enjoy. So we're back post-theoretical, this 2023 cohort of our diploma program. Classmates, Tina Olson, Tim Davis, Emily Dabrowski, and Ruchi Jane, and myself. Thank you guys for being here. I'm looking forward to us chatting and getting reconnected here for a moment after we finish the theoretical. Thanks for being here.
Thank you.
Yeah, thanks, Jason.
So we've got a few others that we were hoping to have with us, but weren't able to catch the same time. It's kind of hard to coordinate 7 or 8 people, at one time to find an hour all at the same time to meet. But we've got a good group here. So thank you guys for taking time out of your schedule. Just to remind people who may have forgotten, it's been a while since they've heard us from earlier in this process, would you give us just your name, where you're from, and maybe just in a brief mention, what you took away from the theoretical? Tina, would you start us off?
Yeah, my name is Tina, and I live in Denmark, work in a clinic here. Yeah, what did I take from the clinical? I learned a lot about evidence. I think we read a lot of different exciting articles, and I think one of the articles that made the most impact on me was the one, I think it was Rastogi and Rosedale, who wrote about how many percentage like if you were having a problem in the hip, there would be 70% of a chance that that problem would be from the back originally, and then you needed to treat the back. And so, yeah, I think that was really interesting to me. And I got kind of all the numbers in my head, and it's something I can use to the patient when I want to explore the back. Then I can tell you, well, that's because there's a 70% of a chance it comes from there.
Yeah, excellent. That was pretty important paper. I think you're right. Thanks for sharing that. Tim, tell us where you are and a bit what you took away.
I'm Tim. I'm from the Northwest United States. I'm in Montana. Big takeaway for me was just we need to be staying on top of research a little bit more regularly. Similar to Tina, I think there's a lot of really valuable educational tools we can use with patients when we're really staying on top of it a little bit better. One of them for me was just thinking about imaging findings and how they correlate or don't correlate with clinical findings. And there was, I can't remember, my mistake not remembering who wrote it and when, but just talking about lumbar disc extrusions and sequestrations and how they were still like, you probably see a high likelihood of centralization even with those findings on an MRI. So being able to take that into account and educate a patient like, hey, there's still a very high likelihood that you're going to recover possibly very rapidly has been helpful for me. So a lot of good takeaways from some of the research we were able to read.
Good article. Anybody? Here's the first quiz question. Who is the primary investigator on that article? When was it? Really? Okay.
Well,
so
ask Hank.
I'm showing off. It's Seneca Kilpakoski in 2023, only because I talked to her about that paper. So I'm cheated a little bit, but that's an excellent paper. Yeah, you're right. All right. Ruchi, would you share where you are and what you took away from the practicum, just in short?
Hi, I'm Ruchi. I'm from Mumbai. Completed my theoretical with you guys. And one takeaway which I took was how to rule out instead of ruling in the provisional diagnosis on day one. Initially, before starting my diploma career, I always used to think of the probability. It could be this, it could be this, it could be this. But now I try to rule out, definitely it is not this. For sure, we are ruling out this. And it's making me more confident with the practice and the diagnosis of the patient.
Yeah. Okay, great. Thanks. Yep. Differential diagnosis is kind of important. So, and I'm like you, I've found myself in the past where, and I'm sure I will still struggle with it at times where have I really eliminated the likelihood this is from the spine? So good takeaway there. Emily, talk to us.
Yeah, I'm Emily Dabrowski, and I am in the northeastern part of the U.S. in Vermont. And my biggest takeaway from theoretical is there's so much evidence out there, so much more than I knew before. I think the biggest thing that sticks out to me that I was open to was the tendinopathy week, and just learning how, like even just with subacromial decompressions, just the degree in which there is the least amount of space in that region. And when we do surgeries, and it doesn't always correlate really with the true anatomical space in that region. So it mostly just opened my eyes to just, I need to be more aware of what the literature really says, just when giving the patients the best advice and what the evidence says and what it doesn't say. My other big takeaway too was just using visual aids more with patients, handouts, just things that are more patient friendly versus just telling them information. And then also using more outcome tools like the central sensitization inventory, just all those different tools to really best treat a patient, things that I haven't been using as much before the theoretical. Those are my big takeaways.
Yeah, really great ones. Nice, good variety there for people to hear about. Thanks for sharing that, Emily. All right. So one of the large things that we did toward the end of that theoretical was to prepare a case report. Pretty big project, at least it was for me. I don't know about you guys, but a lot of work took, we were meant to be working on that all the way through. I'm sure you guys got right on it within the second week or so of the theoretical, and you were timely. You didn't wait till the very end, maybe not, but a lot of time was spent on selecting a patient, using literature and some of the things that we had read about to substantiate your thought processes through, highlighting maybe the keys within the system itself, as to what led you down the path of a definitive outcome for that patient, whether that's referring them on because of some kind of non-responsive condition or sinister pathology, or whether it was a full resolution of their problem because of your skills and your knowledge in the system. So could you guys share just a little bit about the case itself? Not the entire case, we just have a little time here, but in brief, just the case, and maybe one or two little points that you felt like you highlighted in that case. Emily, start us off there.
Yeah, I chose a case that actually some of my colleagues had passed over to me. It was a case of a guy that developed shoulder pain after pacemaker implant, approximately 3 months afterwards. Of course, when he went in with shoulder pain, the question was, is this part of the pacemaker? Is it part of the surgery, or is it more something musculoskeletal? So my colleagues who have taken part A and maybe part B had done some mechanical assessment with him, and it seemed like it was cervical driven. But they were at a point where he just wasn't improving. And then we were risking him going on to getting more imaging, which of course, as we know, can lead to unnecessary interventions. So they had passed him over to me. And then I more just looked at the force progressions, force alternatives, really getting into unloaded cervical retraction, extension, some of those things that are a little more advanced in the cervical mechanical world. And we ended up resolving everything. He ended up leaving 100%, perfect outcome score, never needed advanced imaging or any other interventions. So to me, it just kind of highlighted, yes, mechanical therapy can change a lot of those things that maybe we think could be post-surgical and an other, but it also shows that you kind of have to go through the whole program. Just taking part A and part B, it's great, it's a good start, but it's not the be all end all. You really have to go through the program, finish it to really be able to get the outcomes that are advertised.
Yeah, Emily, do you recall anything that you referenced specifically in that paper that you wrote to kind of substantiate your thought process?
In terms of like research on the different things that I chose?
Yeah, just something off the top of your head.
I mean, there was the XPOS study that I think, was it Tina maybe that was mentioning just the prevalence of extremity pain of spinal source, and just knowing that shoulders are pretty high. That was one that I had referenced. That's the one big one that I recall.
Sure. Excellent. Good case. Tim, tell us about your case.
Yeah, I had a patient who had a bike crash and ended up fracturing his clavicle and sustaining a concussion. So by the time I saw him, he had clavicle surgery done, repair the fracture, and he was still at this point, I think, a month out, unable to elevate his arm past 90 degrees. And he was also having pretty regular vertigo. So after the history and the exam, we determined he had BPPV, benign paroxysmal positional vertigo. And I knew I wanted to at least screen his cervical spine to see if there's any relationship with his inability to elevate his shoulder. So it was just a kind of a problem solving of, do I try to correct the vertigo first, or do I go after the shoulder and neck first? But for me, we ended up kind of just going after the BPPV, clearing the vertigo, because I was like, well, I don't know if I can screen his neck without moving his head right now. And every time he moves his head, he's spinning. So for me, it was just a little bit of what should I prioritize first, and then kind of one of the bigger points for me was the spinal screen. And just thinking about what we were referencing to, I know there was this systematic review that looked at subacromial pain and how often a spinal screen was done, and it was like around 73% of the papers either didn't screen or didn't reference how they did it. So we ended up doing some retractions. There was no change to his elevation, but he started to extend his shoulder a little further. So I think we ended up doing about 55 total, and he had basically full range of motion of his shoulder after that. So for me, it was kind of the emphasis on repeated movements rather than like a single movement spinal screen. Because if we had done, one, to see if there's any relationship, for one, it didn't recreate any shoulder complaint, and two, it took reps and reps in order to elicit a significant change. So for me, that's kind of the big takeaway there was the spinal screen, and we should probably be looking at that even with people post-op.
Yeah, really good case. I appreciate the 55 reps, because you're right. What they say, one of the cardinal sins is not doing enough reps, right? So hopefully we're learning that, and other people can hear that and think about maybe their patients that they've maybe
waned off of persisting with a direction after 15, 20 reps. And sometimes it might take quite a few more. So good
But
case.
also in that case, I think one of the things I learned from the theoretical was that we have that if we're missing something, it's usually that we're not going to full end range, that we're not taking it far enough.
Yeah.
So
great.
the reps and the amount of mobility.
Yeah. Getting to full end range. It's where the magic happens, they say, right? Yeah. All right. Great case. Thanks, Tim. Ruchi, tell us about your case.
My case was on whether the tennis elbow pain is truly a tennis elbow pain. So I had a patient, 47-year-old female, a pre-diagnosed tennis elbow patient. And she came to the physiotherapy clinic and she had these complaints for past 1 year, which was worsening in nature. For the past 3-4 months, she was unable to do her usual ADL activities also with it. And she went through the conventional physiotherapy, electrotherapy, exercises, stretches, everything. And the orthopedic recommended that either we'll have to get you operated or we'll have to give some steroid injections instead if this is not working. So she gave her last try for the physiotherapy. She came to our clinic and it turned out to be a cervical spine source, which and she was lying on with no pain in just a week, as it was truly a cervical derangement which was being referred to the elbow. And she responded to simple retraction exercises, and later on when we just progressed to completely abolish pain, we just went into the end ranges and we did cervical retractions and extensions, and she's really happy and compliant about it.
Is there any study that comes to your mind now that you might have referenced that played a part in this management or assessment of this patient?
So there was one study on lateral epicondylalgia by McKenzie. I think it was in the year 2016, where he had seen similar patients of tennis elbow who responded. I think there were 2 patients. One responded to cervical, purely cervical, and second one, after exhausting the cervical, he went local to the elbow and things were eliminated for them. Both turned out to be derangement with chronic nature pain, but in a week they were much better.
Yeah. Okay, good. So you have different case reports you're able to refer to related to yours. So excellent case. Tina, round us out here. I'll share mine in a moment too, but why don't you tell us about your case?
Yeah, I chose a knee patient. Of course, I had several different patients in my head, but I chose this one because I've been working quite a lot with knee arthrosis. I run some classes and then they come in and if the doctor says this is knee arthrosis, they go directly to this class. So with this lady, I just wanted to explore, did she really have knee arthrosis or was it something else? And I started out with testing the spine. She couldn't hardly walk when she came in. It was quite acute in her knee. She had been walking for about 3 weeks, I think, and it was getting worse and worse. So I tested the spine while she was standing and doing the flexion in standing. She was straightening her knee more and more. And her knee got better afterwards, after the testing of the spine. But then I thought, well, is this really because of we're testing the spine, doing the flexion, or is it her straightening the knee more and more that is helping her? So I decided to make her sit down to leave out the bending of the knee. And we tested out flexion and sitting, and nothing happened to the knee. So that told me that it was probably because she was straightening the knee more and more while she was standing, doing the flexion and standing. And the extension in standing didn't do anything to her knee either. So I moved my focus to the knee and did some testing on the knee, extension of the knee, and that worked pretty well. So I sent her home with extension of the knee, and I saw her just, I think it was 6 days later, and she was so much better. She could walk without really any problems, and she was so happy. Yeah, so she didn't have arthrosis in her knee, even though the doctor said that. Of course, we always have to make our own assessment of the patient, but if the doctor and the x-ray says that it's arthrosis, you're kind of lean on that, and I'm not doing that anymore. I mean, I'll definitely stick more to my own assessment.
Yeah, excellent. How about a study that comes to your mind that you might have referenced in that process?
Yeah, it was definitely again the EXPO study, but I also build a lot on some studies that have been made here in Denmark on arthrosis patients, and I could kind of drag it the other way then, that maybe it's not always arthrosis.
Yeah, good. Excellent. Great case. Mine was a young 30s woman who had 2 years of pain in her back, hip, and thigh. It was around the time postpartum of her youngest child, and she had gone for a year to conventional therapy. And I said, really, continuously for a year? She goes, yes, other than us being away a week or two for vacation, I was in therapy for about 2 to 3 times a week for a year. And she had gotten some relief with her back and the thigh pain, but not full. The hip was really unchanged. Then she went for 6 months of pelvic health specific therapy with a group that specializes in that. And I said the same question, really, for 6 months? She goes, yes, 6 months continuously. And she had a 5 out of 10 at rest. And she was really fairly upset, emotionally just drugged down from the persistence of the pain. She was a physician's assistant, so she would spend some time on days in the clinic and as well as days in the operating room. She was a bit worse on those days when she spent more time sitting and documenting versus those times when she was standing. It wasn't tremendously variable. We looked at the lumbar spine, and in fact, it seemed like there was a noticeable loss of range. So the mechanical piece stood out to me first before really any kind of symptomatic change. She was just a very flexible lady in all directions with the exception of extension. We've all seen that. And it's like, that should just probably move more than what it appears to move. And so we did lots of reps like Tim, your case, and started to see a little bit of a hint. And I thought it's worth pursuing. And so we got her going on that. A visit or two, I think she referred to maybe the third visit where she started seeing there's something here. And so she kept with it, took quite a few days. I appreciated Wernicke's study back a while ago that shows that it takes up to 5 visits, at times to really elicit any kind of centralization or in some cases a directional preference. But so she did improve 50 to 60% ish. However, it plateaued. And so then I realized that, okay, we had to get up into that upper lumbar area. And sure enough, when we got up to L1-2, L2-3 area, she had a considerable drop of her symptoms and improvement in her overall function to I think she reported 80 to 90% improved overall after several days of that. We had to incorporate her husband giving some overpressure. She shared some photos of him doing that, and his form looks just about textbook. So I told her that he may have to, hang a shingle. But so she had a great outcome, which is always nice. And we always look great about that. But I will say that I did reference the Tousignant-Laflamme, if I'm pronouncing that correctly, the 5 domains paper talking about drivers of pain and disability. I think the actual study title is something about rehabilitation. It's time we put it all together, I think is the title. But in that study, he looks at those nociceptive drivers and the nervous system drivers, those things that are comorbidities that might influence a person's pain, what cognitive emotional, and then finally contextual. And she certainly had some cognitive emotional where she was just viewing life that this is going to be the way it is from now on because of that. And so that piece was significant because I had to kind of talk her off the fence, so to speak, of no, let's give this some time. People get well with these things commonly. We just have to trust, that it's going to take a little time and be disciplined with this program. So I actually was able to plot her pain and her function and her yellow flag psychometric scores through the process. And it was interesting because her pain improved, but the psychological things did not as much until later. And then we saw a little dip midway. And I think that was related to her having a bit of a relapse of some of her symptoms, since we know that our patients don't always just improve nice and uniformly and then all the pain's gone and then they get well and stay well. It's more of a up and down process, but as long as the trend is headed in the right direction. So we highlighted that. I actually had interviewed her, which I do with some of my patients who are willing to do that. And so you can kind of hear in her remarks the challenge and that feeling of, am I going to have to live this way? And then going through the problem, what was interesting about this? And she just remarked that because I didn't seem fazed by the persistence of the pain and her history, and the fact that the movement we were doing was making her pain worse in some areas, that built confidence in her. So I think it's something that even our reaction to their pain when they remark about it, we maybe not think about how much that means to a patient. And for her, she said, it reassured me that I'm in a place where I need to be for right now, because you, meaning referring to me, I didn't seem fazed by the fact that her pain was increasing at the moment while we were doing those. And of course, using the traffic light guide to help her understand that one pain might mean continue, another pain might mean stop. So it was a good case for me to put all of that together, like the study of the references of including the psychosocial piece of just reassuring patients and helping them understand the how to self-assess. So excellent. And those were pretty big projects of writing those papers, as you guys well remember. Looking back on the theoretical now, are you hearing yourself or seeing yourself in your mind with your patients now, since we've all been back in the clinic since, do things any differently? Tim, what would you say to that?
I'm definitely giving just less information. I feel like before, what was it, week 9, I was probably just overloading everybody, telling them 25 different things to remember. And now it's pretty clear they're coming back. Yeah, absolutely not remembering any of that. So keeping it to 2 to 3, maybe 5 at most, like really key points, and making sure they understand how and why they're self-managing with the strategy that they're doing that's definitely been important for me. Emily said maybe using more of a visual or writing things down that we really need to have them remember and things like that. So definitely that's been a big shift for me and very helpful.
Was that the Mark Cheel week where he had us remember a cookie recipe?
That's right.
Yeah. Yeah. And so just for listeners, we were put in pairs. You guys helped me remember, put in pairs, and one was given the recipe visually, and we could make mental notes of what that was, but we couldn't write it down necessarily. And then the other person, we had to tell them, or who we were paired with, we had to tell them the recipe. And then Mark came back and asked that person that we told, what was the recipe? How do I make these cookies? And so that was mine as well, Tim. One of the big things I remember and how I've changed is that I have shortened and simplified and minimized what I tell the patient, because I realized, man, I was giving way too many instructions. If this happens, then do this. And this means okay, and this means not okay. So really good point. Tina, what did you take away that maybe you've applied in your practice already?
Well, I stick much more to the assessment form. I wasn't using them that much because, I have been doing a lot of other stuff ever since I took the MGT program way back in 2000, I think. And now I'm sticking more to the form again. And I'm not focusing on the structure that is wrong. So it's much more, we don't know what's going on in there, but if this exercise can help you, then who cares if it's a meniscus or if it's a ligament or if it's a bone or the muscles. We don't really care. We just need to move it around to get the blood flow increased in there, and that might be the thing that is helping you. That's usually more my explanation to the patient now. And I think, was it you that said earlier, Tim, about the disc? Well, we don't know if it's a disc that's a problem in the back, for example.
Mm-hmm.
So,
Good. Yeah, excellent. Ruchi, what about you?
So I agree with Tim that giving less information to the patient is a good key now. And one thing that initially I told you during the introduction, that radiculopathies was a big challenge for me. But now I'm enjoying to treat them. When I treat them, I'm really finding different natures of radiculopathies. And now I know what I'm doing, where am I heading towards. So that is a bit interesting. And apart from that, with extremity patients, screening cervical spine or lumbar thoracic spine is a bit quicker, which earlier I thought it's going to take a bit longer. Let's not do that. Maybe not go with every patient, but now I make sure I go with every patient. And number of sessions reduces for the patient eventually.
Yeah, excellent points. Yeah, so whereas some conditions might have been a bit intimidating and you felt a little less confident, now you're a bit more confident. Yeah, that's a good point.
Definitely, I don't know everything about radiculopathies, but I'm heading better.
Yeah, Yeah, excellent. Emily, share your takeaways and how you might see your practice changing.
Yeah, I would say one of the big takeaways was just having such a diverse group of people. There were 12 of us, I think. Everybody sort of brings in their own analogies, because patients, they get analogies. They don't always get, our mechanical medical description of things. But I know one person mentioned like the hinge on a door and it's not closing all the way, and just giving them that analogy. One new one that I took away was the bank account analogy, because so often patients are doing their press ups, but they're gardening, they're bending. But I was like, the press up, right, puts money in the bank account, and then all of your forward bending takes money out. And if you go into the negative, well, that's where your pain is. So I've recently had a lot of patients that are just completely receptive to that. They get it. It puts them more in that empowerment, like, okay, now I know why I'm doing this. I'm controlling this versus I'm checking a box. I'm doing it every 2 hours. Why is it not better? Kind of mentality. So I think just having that just group of people to bring in their own different analogies was really valuable. Having the literature behind me just to justify why I'm doing different things has been helpful. Because of course we all know that with back pain, there isn't a structure, in current evidence that really is supported. It's more just the classification, how do they move? So, but it's also hard to tell patients that, because they don't like hearing, well, it doesn't really matter what the structure is. We know what to do. Like, they don't always like to hear that. So I think just having the evidence that says, hey, these studies actually say this. Not that I'm giving them any different medical explanation, but it just says, yeah, it sounds like, I'm like, yeah, it doesn't matter. But no, this is what the research shows. And I've spent time going through the research with people from around the world. It just kind of gives me a little bit more credibility in saying some of those things. A couple takeaways. So I've got some colleagues that did the diploma program last year. And so just some takeaways that I've heard even from them, things that they've learned were just slow down, right? Some of the cardinal sins, going lateral too fast, jumping the gun, some big takeaways that's true, right? Just slow it down, right? Look at sustained, look at other things before you jump to maybe it's not this, maybe it's that, just slowing it down. And then I know one comment one of the faculty has made was, your life is busy enough, just keep it simple. Right? Because sometimes even a patient yesterday was like, that's it, just one exercise. And prior PT, I was given 8 exercises. I'm like, I know, but your life is busy enough. We'll just keep it simple for you. It's okay. So just some of those little phrases, patients, they then get it. They're okay with that. It's just not what they're used to. So I guess a lot of little clinical pearls is my biggest takeaway. I did not leave theoretical being this big earth shattering, like, whoa, I just learned what the McKenzie method is. It's not like that initial earth shattering feeling, but it's more just taking all those little things, knowing I still have a lot to process, a lot to learn, a lot to keep up with, was my big takeaway.
Yeah. Excellent. Really great takeaways. Good stuff. Tim, tell us where you're headed for your practicum and how you're feeling about it.
I'm heading to New Jersey. Should be probably just exactly like it is in Montana, I would imagine. I'm feeling good about it. Definitely, I'm nervous going into a situation like that where, we're just going to be probably just continually exposing my deficiencies as far as history taking and physical exam and communication. But I'm definitely looking forward to the end result being I'll be able to, help more people than I was before. So it'll be great to learn from an expert, and especially for that much time.
Mm-hmm. Tell us who your clinical instructor is going to be, and tell us a bit about the practice and what you understand a day is going to look like there, or a week.
It's with Todd Edelson, and he runs a private practice clinic. And I want to say there's at least 3 12-hour days during the week, and maybe a shorter day somewhere in the middle there. So it'll be pretty rapid fire. I think we'll be seeing 20 to 24 patients on the long days, which is quite a bit more than what I'm doing now. So we'll be keeping busy on those days. So I'll definitely have to improve on my efficiency for pretty much across the board.
Yeah, excellent. All right, it's exciting. You're feeling pretty good about it.
Feeling good. Looking forward to getting better though.
Good. Tina, where are you headed? Tell us about it.
Yeah, I'm heading to a small town in Denmark called Skanderborg. I'm going to have 2 instructors, Klaus and Annette. And I'm going to be there with a fellow student too. He's from Denmark as well. And so we're going to be there together. And what I heard so far is quite another story than you are telling, that we are having like normal work days. We are going to work 7 to 8 hours a day. And then we're going to read another 2 and 3 hours a day. And they're going to be very flexible. So if we need to go home early one day, we can do that. And as far as I know, we're going to see about 3 patients a day. Yeah, and then we're going to do some practical training on each other, I think, as well. So that's a little different, but I'm looking forward to it.
Yeah, and Tina, you mentioned 3 patients. That's 3 that you might assess or reassess, but you'll also be observing other patients that your clinical instructor's working with?
Well, I don't know.
You're not sure about that? Yeah.
No.
All right. How are you feeling about the practicum? Are you anticipating that I've got this, or are you a bit nervous, or you feel?
Oh, I'm pretty sure that I'm going to work hard every day. Yeah, so I'm planning on staying in that town, even though it's just 1 hour, 20 minutes drive from my place. I'm pretty much staying in the town where I'm doing the practicum because, yeah, I don't want to spend the time on the highway. I want to spend time on reading and then rest of the time just making my head clear now and then. Yeah, I'm very much looking forward to it. And I think it's going to be very exciting. I think it's going to be tough. But I also heard somebody say that you're never really taken out of your comfort zone, even though, I mean, you're pushed to the limits. But I think it's nice to know that it's not going to be a test of you all the time. You're going to be there to learn, and they're going to teach you stuff. It's not you just showing them what you know.
Got it. Yeah, that's excellent.
But as you mentioned earlier, Jason, that you feel like a school kid, I think it's going to be that way.
Yeah. So before we started recording, I was just sharing my experience because I'm finishing week 6 now of the 9. And at times I hear myself or see myself second guessing where I'm taking the assessment or the physical exam. And I'm thinking in my mind, just, see this patient. Don't worry about what they're thinking or what they'll say. They'll correct you later or give you their thoughts. But so, yes, at times I have felt myself in the first few weeks of second guessing myself, I guess, and not trusting that not that I don't have plenty to learn. Of course I do, but I also can examine a patient, somewhat efficiently and effectively. So, and I will say I'm jealous of you, Tina, having another student with you on a practicum. I would say that's probably one of the biggest things that I wish that I had probably listened to Chris and Kim and Richard saying, you can do it in the summer, but you won't have someone there with you. And I realized, wow, that really would be advantageous to go through this process along with another student. So that'll be a great experience. And Tina, you didn't even share the most amazing part of what you're going to be able to do while you're on that. Come on, give it up. Tell everybody.
Yeah, but that's so extraordinary, and it's never going to happen again because my instructors, they are also instructors on the C&D courses, and they're going to do a C&D course in Spain on the practicum week 2. So Tu and I are going to join them to go to Spain. So
but not just Spain. Where in Spain?
Oh, Fuerteventura, and that's a small island where they do a lot of sports. Yeah, so it's just going to be fun being down there for a full week.
Yeah. Canary Islands. It's a tough place to have to go to work, but
yeah,
that'll be nice. Excellent. Yeah. Okay. Thanks, Tina. Ruchi, tell us where you're headed, when you're headed there, and a bit about what you anticipate and how you're feeling about it.
So I'm actually not thinking much about it right now because I'll be going for my practical component next year. It will happen in Montreal, Canada, under Michael. But things turn out, fingers crossed, we might start. It would be good to see any clinical site in India. If that happens, it would be great for me.
Got it. Okay, yeah. So it's a ways down the road, and you're not as worried about it because you got some time before you have to go. Yeah, but potentially with Michael Dyke there in Montreal, but perhaps things develop maybe in India, you say. Yeah. Okay, very good. Emily.
I have a lot of mixed feelings, I think. I mean, the biggest one for me is I know that everybody going through the program has different, family situations and everything else. I've got 3 kids, a 6-year-old and twins that are almost 4. So in a way, I'm just excited to get out of Dodge, which I know sounds awful, but it's like, you just remember what life is like before kids, right? You're studying, and even like internships after college, like just how valuable that lifestyle is, just to take care of yourself and focus on you and just growing yourself. So on the one selfish half of this is just looking forward to having time to sit down and go through my theoretical notes and just immerse myself in this, because like I was saying before the podcast, it's just, you finish theoretical and it's such a ride, but then it's gone, right? And there's nobody there to push you and force you to do these things by a certain deadline, and life gets in the way, right? You're still working full time, you got kids, and it's just hard to grow further once that formal program is over, at least in some aspects. So in that aspect, I'm excited. I'm nervous, I guess, because I haven't been a student in like 13 plus years. So just to be around other people that are just, I mean, not criticizing in a bad way, but giving me feedback is amazing, but also terrifying. So just not knowing what to expect is anxiety provoking, but I'm excited, I would say. I guess we'll hold it against Jason that he didn't want to go in the fall, so that neither of us have a colleague to go with. We'll blame him for that. But yeah, it'll be cool. It'll be nice to still almost like 2-on-1 attention when we're there. But I think it probably is, valuable moving forward for other folks to have somebody there with you that I'm guessing you can bounce ideas off or stay late and study or whatever it may be. So, yeah.
I accept the criticism, and you're right. I should have listened. But however, I do have to go home to my family, and they said, nope, do it during the summer.
No, we won't hold it against you. Or just,
But I will.
But I'm with you.
I will commit that when you want to chat in the evenings about something, you let me know. We'll set up a time where we can kind of compare notes.
Sounds good.
Tina, you had a thought maybe about what Emily was saying.
Yeah, it was about the kind of gap that came after we had finished the theoretical. I was thinking, well, I got to read some more. I got to, just read some more articles. So I signed up for another course, Explain Pain. And I followed that for 6 nights, I think it was, every time online. But it was just so strange to be with other students than you. I mean, I missed you there. Yeah.
Well, good. I'm glad you're kind of keeping your eyes on what else is out there on pain neuroscience education. And maybe there are some things you thought, I think we do that a bit differently or better. Or maybe you thought, no, there's a good piece to add to how I assess a patient, how I educate a patient. So you'll have to share some of what you learned maybe with us down the road. But any other thoughts you guys have that you'd want someone else to know who's considering the diploma program? And, is it something is it worth the time? Is it worth the money? Is it worth the disruption to my life and all the challenges?
It definitely is. I think I got so high. I mean, I felt so that I got new skills, and that made me so confident in my job, even though that we are learning a lot and we don't know everything yet, but it just gave me a kick.
Great.
So I was, yeah,
that's good to hear. You guys agree? Yeah, go ahead, Emily.
I don't know. I've got mixed feelings, I think, right now. I don't know, like it's expensive, it's a lot of money, and that doesn't even factor in the lost wages when you're gone for 9 weeks, the cost of either renting a car or renting space to live during the 9 weeks. I'm hoping at the end of this, I will say for sure, and I have no regrets in doing this at all. I would say constructively, I mean, the first, 12 weeks, you're just reading research and we're discussing, but there were even some weeks where it's like, I just felt like this could have been an independent learning experience. That was just my opinion. Some weeks were very interactive. There was some great feedback from the instructor, but others, I'm like, I paid $7,000 just to read articles on my own and discuss a little bit. So just, I guess, to be critical, financially, did the first theoretical have to be so expensive? Did we need $7,000 just to get access to those articles? So at least for the first half, my question is, could it have been cheaper a little bit? And I realize, education's expensive and it's valuable and no regrets. It's just like, that's a lot of money. And of course, at least in the States and probably around the world, our salaries are not going to increase at all. This might create opportunities where maybe we have pockets of things we can tap into, but we are not going to come back to work after this experience making more money. So we're going to be in the hole financially. So that was just hard. So yeah, I don't know. And plus, I haven't not gone through the clinical part yet, so that might change my experience. I think in the end, after having to be responsible for so many articles that I can recall in a second during an exam when you're already nervous, I'm sure that after that I'll feel like, whoa, I know my stuff. At least until it changes in 3 years, right? I'll feel good. But right now I'm just kind of like, I don't know. I would love for everyone to go through this. I love MDT because it's a great assessment. You can't force MDT on treating everybody because MDT just tells you how you should be treating. It might be referring out. So I preach MDT. I think it's amazing. And I'm just so fortunate that I've discovered it. But I guess I'm hesitant referring the program to other people just because I think things could be done a little bit differently. But I think, I think the faculty are very receptive. Richard, I think, is great at, receiving feedback. So I have all the confidence it'll keep growing. It'll keep improving with the times as times change. I've just kind of had some mixed feelings along the way so far.
Well, yeah,
to be honest.
Yeah, thanks for being candid about it. And actually, I was kind of surprised because Tina, you had described earlier on that you just weren't sure. Gosh, are we getting what, are we receiving what we paid for and all those things? And so it sounds like you have come to realize at the end of the theoretical that, okay, I'm content with this so far. And then Emily, I don't know that I heard the same kind of feel from it midway or even early on. So this is interesting that you're questioning, and I appreciate the fact that you almost feel a responsibility to share with people accurately, not just to paint a picture with rose-tinted glasses on of the program. And so it really does take some self-evaluation and what do I hope to gain by doing this, and how important is it to me, and where am I in life? So yeah, you got a comment. Go ahead.
Yeah, and I mean, I wonder too if it just depends on where you work and kind of what your setup is. I mean, at least some clinics that maybe would foster, hey, you're going to go through this program, maybe we'll financially help you, maybe we won't. But, when you come out on the other end, let's get some programs in place. Let's connect you with our spinal surgeons or pain psych, like get an interdisciplinary team formed as a result of, wow, like this, our company is, fortunate to have you dedicated to go through this program. Let's collaborate on how we can use that knowledge you're going to gain. Yeah, I think that might be favorable. Whereas I work in a hospital system where they don't care. I have been point blank told you're only paid based on how long you've been there. Your outcomes do not matter to us. So there is no future for me to, hey, let me help grow you, right? There's none of that really there for me. So the part of me is like, I'm doing all this for me and I want to help my community. And this is amazing to kind of help grow a clinician to help to improve their population health in their area. But I feel like it's going to be a dead end with me where I currently am, which might put an external sour taste in my mouth on what am I doing? Where am I going to go from here? Am I being equipped with the right tools, or is it just where I am location wise? It's kind of made it harder to really, really utilize all this knowledge that I'm gaining.
Mm-hmm. Yeah. So maybe the setting that you're in might play a bigger role. And maybe your future goals, or what do I really want to do with this? And if it's to set up an interdisciplinary specialization of mechanical musculoskeletal problems in your area, then boy, it seems like
move.
Yeah, I was going to say,
I'm pretty sure.
You know better.
Yeah, I don't know. Just things I got to think about.
Sure. Tim or Ruchi, you guys have a thought on this question?
Yeah, for me, I think, big takeaways there is like, yeah, it's definitely a huge investment. And that's a good point, Emily, that it can be, based on where you're working, it can kind of influence what you're able to do afterwards and where you're able to take this. But I definitely agree. I think I'm on the same page, like, at least on an individual level, if we can improve in a way that's going to help our community, at least the patients that we're seeing, I think that's huge for me too. So that's kind of that's a motivator for sure. But yeah, I think that's all I have on that.
Yeah. Ruchi, you agree, or what are your thoughts?
Yeah, I agree with Tim and Emily, but thing is that from week 1 to week 12, how much input we could give all throughout the program. Like I was not able to read each and every article, those extras, and sometimes the amount of attention which I was supposed to give for the 12 weeks was not constant, equal all throughout the 12 weeks. So I feel whatever I have grasped from those 12 weeks is good enough. Like I'm dealing better with the patients. My patients are getting happier. I'm taking less money from them. Sessions are reduced, and that is making me happy.
Excellent. So maybe if there is no financial improvement, just your contentment of what you're doing. And at the end of the day, you know, you're providing as good of care as you can. Yeah. Yeah. Excellent. So what we'll do is we'll plan on trying to capture some more discussion as more of us begin or finish the practicum, the clinical residency portion down the road, and perhaps even as we prepare or even post the examination process, which is that a whole other piece. So I was sharing before we were recording that I'm realizing I've got a lot of work to do between when I finish the practicum and when I'm ready to take the exam, just from being able to speak off the cuff, so to speak, and substantiate any of my opinions and thoughts and decisions and actions in that exam with literature and with best evidence. So the work is still not done, but that's all right. We're learning through the process. Tina and Tim and Emily.
Never be done.
Say again, Ruchi.
It will never be done.
No, that's right. You're right. You're right. Good point. Tim and Tina, Emily, and Ruchi, thanks guys for sharing some of your thoughts about where we are in this process. Thanks for being candid and giving us your outlook on things, what you've taken away. We appreciate you guys. I'm grateful for you guys, and we'll connect in the future.
Awesome. Thank you, Jason.
Thanks, Jason.
Thanks.
Thank you.
Okay, so there you go with episode 396. I hope week by week you're getting a clearer picture of the program and whether or not it's a good fit for you. From seeing their clinical reasoning undoubtedly sharpening to questioning, is this really all worth it? A wide range of emotions and perspectives. Stay tuned to catch back up with some of us in our clinical residencies, specifically Tina, who you've heard from several times, and Tui, another of our cohort you haven't met yet, and their two clinical instructors, Klaus and Annette. That's coming up next episode. Be sure to subscribe to my email updates to be notified of new episodes. Subscribe to the podcast on your favorite podcast player and my other social media channels, as we'll be notifying you when each episode comes out. If you're hearing the audio version, do know that we are releasing video versions of the podcast on our YouTube channel as well. Again, I want to thank today's sponsor, the McKenzie Institute International, providing worldwide training and support to clinicians in the principles and practice of the McKenzie method for the management of patients with spinal and extremity disorders. The McKenzie Institute Diploma program provides the highest level of MDT training. It enables clinicians to acquire an in-depth understanding of the McKenzie method and become experts in its effective use in guiding their patients to achieve their personal goals. If you have an interest in learning more about the diploma program, check it out at mckenzieinstitute.org. And don't procrastinate. If you want to apply, you can in this program through mckenzieinstitute.org through October 31st. And don't forget, here on Mechanical Care Forum, we're continuing to plug away with new cases within Case Conversation. That's our patient case discussion resource. And new scientific studies within Inside the Science. That's our peer-reviewed summary and discussion resource. Currently, regarding cases, we're highlighting the topic of subgrouping within the classification Other. When it's not derangement, dysfunction, or postural, what is it? And within our research resource, we're spotlighting papers on the reliability of SI joint provocation tests and validity within a mechanical examination. These resources, that is, Case Conversations and Inside the Science, are intended to provide some virtual mentoring for you and help keep moving you forward in your professional development. You can check them out at mechanicalcareforum.com. All right, I wish you a great week with your patients this week. In some way, commit to difficult things, which are proven to make you better. You won't regret it. And join us right back here next week for more from Season 13 and sharing experience for improved patient care.